little bit about the Sheffield Children's NHS Foundation Trust. It's an acute hospital with a trauma department, and we also have an adolescent mental health facility and various clinics, specialist clinics across the city, comprising of about another 7 to 10 sites. When I was asked to put this PowerPoint together, I wanted to bring us together to try and relate security and facilities management together, and how we can work on things, certainly from our trust and how we are coming together to try and form and be proactive in the increase in violence and aggression and the new Martyns Law bill that is currently going through Parliament at the moment. So for those that don't work in NHS directly, some of the stats which are quite shocking. Violence and assaults against NHS staff. Around 75,000 people each year experience physical violence and aggression from patients and public. According to the staff survey in 2021, 14.3% of workers had experienced at least one act of violence. And just to give you an idea of that, that's over 200 violent attacks a day. The ambulance service doubled these figures, which is quite shocking. And this has happened year on year for the last 5 years. Personally, at the Sheffield Children's NHS Foundation Trust, we've seen a significant increase in verbal and physical aggression against staff year on year for the last 3 years. This has resulted in an increase in sanctions such as conduct warning letters, bans from premises, and even restraining orders for parents and visitors. And I just want you to remember that whilst we talk about this, we've got to remember that this is just a paediatric trust. It's just for children. So I'm not in the same position as Kerry, for example, who has a mixture of adult and children's hospitals. This is just for children. It's quite sad to see that in a paediatric trust that we are experiencing this increase in violence against staff year on year. So, the Violence Prevention Reduction Standard was published in 2021. Significant piece of work. The standard is a risk-based framework that supports safe and secure working environments for staff. The risk takes shape through the plan, do, check and act approach. So what does this mean? Firstly, the NHS must revise their current status against the standard. The standard is a huge 300 sort of phrase document, about 30 pages of risk-based framework, reporting procedures, support mechanisms, how we're reporting it at board level, how are we conducting training at operational level. So we must assess, the trusts must assess and manage the risks and implement resources and training accordingly. For example, conflict resolution training. Who needs this based on the evidence? And this is my role and Kerry's role, for example. We are the operational team that decide based on statistics, based on framework, who and what staff are at most risk. And from that, we can then deter at what standard of training they will need, whether that is hands-on physical restraint training, when is that just de-escalation training, or e-learning, for example. The Trust must audit the processes that have been implemented. Our Trust audit our processes every 6 months until we get at least above 90% compliant, and then we will probably go to auditing this once a year. And then we review the performance with senior management and exec teams to inform any changes, policies and funding. So how we started to implement the guidance. We brought a working group together to support the initial risk assessment against the standard. The group consisted of senior nurses, unions, a lot of FM involvement, human resources and equality and diversity networks. We created a working plan with roles and timescales, and we reviewed our policies and strategies for the violence and aggression towards staff. We reviewed this every 6 months, like I mentioned before, until we thought that we were 90% compliant. We're still not there. We still find that we have a few flaws, and we're going to continue to work on this until we get to that 90%. So what are the operational factors from a security perspective? What did we have to do? So following a risk assessment, we found quite a few flaws in the lack of physical security in the Sheffield Children's NHS Foundation Trust. And I just again want to refer back to the word security and a children's hospital. It's quite sad to think, but one of the main features that we implemented was a £250,000 investment to employ 20 security personnel in a children's hospital. This is due to the violence and aggression against staff, whether that be in our emergency departments or on wards. This wasn't included in our mental health facility. We increased all emergency hardware, such as panic alarms, bleep systems. We did a full trust review of where we needed to put these systems. We needed to also look at protective screens in high-risk areas such as emergency departments, outpatient departments and clinics, and also community clinics. We then assessed all the conflict resolution training across the site, and we found that as a result of the statistics following our risk assessment, certain cohorts of staff needed an increase in conflict resolution. So some of the staff that would be admin staff, for example, would look at our e-learning. But due to a 48% increase in verbal abuse via telephone to our admin staff, we found that that training was no longer significant for them. So we invented a 2-hour face-to-face session for admin staff. This all came about after an incident whereby a staff member went off sick. This really sort of touched the strings, which made me create and form this training. And this was a staff member that had been on the telephone to a parent of a patient that was in a clinic and being verbally abused for 45 minutes. And when I sat and debriefed this staff member, they told me that they felt that if they terminated the call, they would be fired. So this poor lady had been verbally abused for 45 minutes by the father of a patient because the training that we were providing at that point wasn't significant enough. So we restructured the entire training. What we found is a lot of facility management or facilities operational staff didn't access the training. They didn't have access to the computers. They're very operational. They don't have time to sit down and go through these sort of things. So we implemented guidance and face-to-face training and lent on managers of FM groups to make sure that they attended the training and were compliant. Sorry, just to mention, the biggest increase in conflict resolution training is that now we decided at the acute site that facilities management would actually act and receive the level 2 conflict resolution training in restraint. We found that the porters, domestic staff, were some of the highest numbers of being assaulted, whereas we would think usually that would be clinical teams and nurses, but actually domestics, engineers, facilities management that work on live ward areas, and especially porters, made up quite a large number of staff that were physically assaulted. We implemented, especially for the portering team, a 3-day restraint course and de-escalation course at the acute site to try and avoid this and decrease the numbers and provide staff with the tools to be able to act accordingly in these circumstances. However, everything I've just said is no good until you have staff that are reporting it. We held the staff survey in 2022 and found, quite shockingly, that only 2/3 of staff in the hospital reported incidents. We use a reporting system called Datex. Some of you may be familiar with that. And we found that a number of colleagues were not reporting incidents due to not knowing what to report, not knowing how to report, and some colleagues just thought it was a tick box exercise for execs to be able to retrieve funding from the government. We needed to make sure that staff knew how to report and the reasons why, and the need to report, so we could proactively implement such systems and increase training. So this led to a 3-month campaign called Report for Support. This was a campaign that I held over 3 months in the form of drop-in sessions, workshops, regular comms, posters, flyers, desktop adverts and videos added to the intranet, also included in the trust induction. The end result of this was to empower staff to report incidents in the knowledge that being assaulted or verbally or physically was not part of their role, which was another common theme that we found, especially with clinical colleagues, is that being verbally abused or physically abused, dependent on the acuity of the child and the diagnosis, was acceptable in some circumstances, which is quite clearly not. Glad to report after the campaign that we saw a 22% increase in reporting. So we took it right back to the bone and decided to revamp the reporting mechanisms to encourage all staff to report. And now when they do face an incident of verbal abuse or physical abuse, that goes into a DATEC system which is picked up within 24 hours, and there's a sanction put in place immediately. That sanction could be in the form of a warning letter, it could be in the form of a ban from premises, or it could be a police report as well. It also helps us with our stats to see if we have got an increase in hate crime reporting, physical or verbal. So it's a really good campaign that got us moving quite quickly. The second subject I wanted to talk about, which will affect everybody in this room, is the new Martyns Law bill. So what is this and why is it happening? It's a result of a tireless campaign led by Mrs. Murray, the mother of Martyn, who was murdered on the night of the Manchester bombing. Just a few stats for you there. There have been 15 terror attacks in the UK since 2017. The government have decided we need to improve security and ensure robust and proportionate and consistent measures are in place. And like I said, this will affect everybody in this room. It will place a requirement on those responsible for certain premises and events to consider the threat of terror. How will it work? 2 tiers, standard tier. This will apply to qualifying premises with a maximum capacity of 100 or more. And as you can see highlighted in purple, it will include a completion of a plan to ensure better preparedness, free training and awareness training. An enhanced tier, which I'm assuming will be most of the people in the room, will apply to premises and events with a capacity of 800 or more. This could include live music or events or NHS premises. This is a little more complicated. We are looking at a risk assessment and a security plan conceded to a practical level, including systems and processes to mitigate the risk of a terror attack. So facilities management involvement. To provide terrorism training for staff, CCTV and badge access review, involve facilities management in the initial risk assessment, lockdown plans and standard operational checks. We created a working group to get through this. Facilities management were really, really heavily involved in the working group. So how does this relate to the facilities management team and what did we do in the hospital? The work so far is, as I've mentioned, we involved a working group for facilities management. We looked at hostile vehicle mitigation assessment. This was with the counter-terror police, and we had our emergency department and outpatient department and car parks assessed by the counter-terror police, who suggested an improved ways of working and also how we could mitigate hostile vehicle mitigation. We had terror protection training assessment. We are currently going through this at the minute, so we are looking at rolling out training to all domestic teams, portering teams, security teams with counter-terror training. We are yet to find a package that we think would suit everybody, but this is some ongoing work, and we hope to have this sort of wrapped up within the next month. The reason why we're rolling it out to these teams is because these are the operational guys that are on the ground. So these are the ones that will see and witness suspicious activity, suspicious behaviour, suspect packages. When the bill comes out, it may request more than these operational teams. It may request everybody within the premises to have this training, but yet we haven't had sight of this. So I know myself and Kerry attend a National Performance Advisory Group meetings every month, every 3 months, and we are currently updating and waiting for a mock risk assessment to come out. We need something to be able to feed into, something that we can move forward and be able to give us an idea of what is needed within the premises. But proactively, being able to provide training, find the training for the porters and security teams, and heavily involve them in testing procedures, lockdown plans, suspect packages plans. For example, at the acute site, as part of our emergency preparedness and resilience, we must hold a patient abduction plan every year. We must hold a mock bomb threat every year. We must hold a hospital lockdown every year. Historically, this was just done with the security teams because that's essentially what it relates to. Over the last 12 months, the facilities management team, as in the engineers, the porters, heavily involved in these plans now. The porters at the acute site will help lock the hospital down. They will be part of that search team for the suspect package and bomb threat. So this is really how we are managing to create a larger working group and involve everybody with eyes on the ground. So we're ready for the Martyns Law bill, whatever that might be, when it comes into play. I'm hoping that proactively we need to increase these numbers as security personnel are never ever going to be enough just to do this. It needs to be everybody needs to have a buy-in for it. And like I say, we are waiting for the official risk assessment, but being proactive, I think, is the way to move forward for this so far.